Yeah, otherwise, keep. Go. Yeah, please start.
Hello, everybody, and welcome to our last and final session. The topic of today's session, Session 4, is Quality of Life Evaluation. I would like to now welcome and introduce my co-chair, actually.
Yes, I'm Paulo Kassab, a surgeon from Santa Casa, São Paulo, Brazil. Thank you, Adriana.
Thank you. And our first speaker is Luca Baiocchi from Italy. Please welcome to the podium.
So, Chairman and esteemed colleagues, ladies and gentlemen, thanks so much for this kind invitation. I'm very happy to be here in this special session. My name is Luca Baiocchi, and I'm full professor of surgery in Brescia University, and I work in Cremona Hospital. Brescia and Cremona are two small, 200,000 and 100,000 people town in northern Italy with a pretty Roman history and a beautiful downtown. Please visit if you can. I don't have financial disclosure, but I do have scientific disclosure. Bilal Al-Kafaf is an upper GI surgeon from Manchester, UK. He's a good friend, and he's the PI, principal investigator of the important study, the Gastro Study, which I present to you in a few minutes, and I share with him some slides. Moreover, let me express my happiness and my congratulations for having organized this meeting with patients, because our final goal is take care of patients. But the only way to improve the results of our therapeutic path is having a continued and effective scientific research. And in turn, having a good research needs the support by the society in terms of financial support and motivation. And so the alliance between the care, research, and what in Italy we can subsidiarity, which is not exactly solidarity, is, in my mind, the best way to deal together this terrible fight against gastric cancer. And in this alliance, I will present the surgeon corner. And surgery is somewhat different from other medical specialty, because when you decide to have your abdomen cut by a guy, you should really trust on him. So the relationship between the patient and his surgeon is so particular. But this can have as a consequence that surgeon develop a super ego, which is only directed to his beautiful surgical field, to the number and the reproducibility of procedures. And for progressing in surgical culture, we should excise the ego and look to something outside the surgical theater, which means for patients, first of all, life, and second, and very important, quality of life. So I would like to present to you two examples of studies in which the surgical ego has been cut, and some attention has been paid to the quality of life of patients, the Gastro Study and the Gastro Screening project. The Gastro Study was an international consensus including patients and healthcare professionals aimed at having a core outcome set. And it was led by Bilal Al-Kafaf, and the rationale relies on the knowledge that priority of patients were different from priorities for surgeon and for researchers. Look at this. The outcomes reported in trials were completely different from the outcome reported as important by patients. For patients, surviving was important, but the long-term impact of surgery were also important. And instead, for researchers, the technical aspect, the adverse events, the recovery were more important. So in 2019, in Prague, during the International Gastric Cancer Congress, Bilal was successful in including about 25 centers from all around the world, and his study was then run through the stage number 1, during which he identified some potential outcome from systematic review and patient interview. And the stage number 2 was a Delphi survey starting from 56 items and including patients, nurses, and surgeons. And the consensus meeting was unfortunately held in Manchester in March 6, 2020. So it was the first days, the first weeks of COVID pandemic in Europe. I was personally ill in hospital, and so I attended this meeting by online. This survey was translated into 8 different languages, and finally he got about 1,000 answers from patients, surgeons, and nurses from 6 continents and 55 countries. And finally, we got the list, including some points of survival outcomes, but also important points of quality of life and also post-operative complication. What the meaning of this study, what the result of the study, having this core outcome set should allow for a best trial design with relevance to patients, for national and international audits, and finally to have a clear discussion in terms of consensus with the patients. So thanks one more time to Bilal Al-Kafaf for having designed this study. And the second one is the Gastro Screening. What is the best method to avoiding the impairment in quality of life? Not removing the stomach. And we can hope not to remove the stomach only if we make a diagnosis in very early stages. So in Italy, we have this charity foundation, Ricerchiamo, which was founded by the daughter of a patient dead for gastric cancer. And the mission of Ricerchiamo is to support the scientific research in the field of gastrointestinal diseases. In 2021, Ricerchiamo, I am the scientific chief of Ricerchiamo, we launched this study, pilot study, feasibility of population-based gastric cancer screening in West. And we did put 100,000 euros on this project. And the first phase, the most important phase of the project was the setup of a tool for a first-line analysis of patients with the aim of investigating which patient would undergo second-line invasive investigation. And we found with the epidemiologist of Verona University, Professor Verlato and Dr. Martinelli, a questionnaire, which is called the Gastro Form, with 34 questions. And the second step is actually ongoing, offering to the patient identified by the Gastro Form as slightly more risky of having some important information from the endoscopy, the upper gastrointestinal endoscopy, maybe some new cytology or some circulating new DNA will be also useful for this study. And the third step will be, we hope in the future, validation on the larger scale. The Gastro Form was built on personal data, anthropometric data, and very important risk factor we've got the smoking, familiarity, previous intervention, diet, and obviously we included also some protective factor from diet, from physical exercise, and also non-specific symptoms such as bloating and reflux disease, but most important warning signs such as dysphagia and anemia. And the gastroform was then distributed by the Ricerchiamo Societies, so patients and other kind of general population and with general practitioner. In only 20 days, in November 2022, they gave 5,000 forms, and our epidemiologist, Professor Verlato, finally identified 16% with a slightly higher risk for having some useful information from gastroscopy. So it means 250 upper gastrointestinal endoscopy. What can we expect? Usually in the normal population, we've got 0.019% of early cancer, 9% of atrophic gastritis, about 2% of Barrett esophagus, and we hope that with this kind of selection of patients, we can raise to about 30 to 40% useful information by upper gastrointestinal endoscopy. And this is the first step in the direction of making it possible to perform some kind of screening also in Western population. And so in conclusion, I really enjoy the title of this patient advocacy session. Developing patient advocacy is useful for ensure that the views of the patients are reflected in our decision-making process. This today is a small opportunities, but it can become